Good afternoon, ladies and gentlemen. Welcome to another edition of the COVID-19 update webinars from ICR at Setia Alam NIH. I'm Christopher Lee. First, let me wish everybody Selamat Hari Raya. We are on the 5th year of Raya, so it's still very much in the Raya mood. The parking lot is very empty today, so I guess a lot of people still on leave. We hope everybody had an interesting Raya this year, very unusual COVID Raya, I guess. The good thing about this Raya is I ate a lot less, not because I had good willpower, because there was no food, no visits, no open houses. So I guess there's some collateral benefit to this Raya. Now, today we are looking at, of course, another aspect of COVID-19. Today, we must apologize to some degree. It's a bit of a mixed bag because of scheduling issues. We have to mix certain speakers together. We have first of all we'll be talking a little bit about the issues of postmortem and what are the postmortem services in relation to COVID-19. And we'll be hearing from the expert in that area first, followed by three speakers who will be looking at a very important aspect of COVID-19, something that we have talked about a lot. Quite a lot of data has come in from overseas, perhaps not so much from our own local context, but issue of mental health and its problems related to COVID-19, especially during the lockdown period. So we will have three other speakers talking on that topic later on in the program. So because of scheduling issues, we have to mix the four of them together. So in terms of Q&A, of course, the Q&A will happen at the end of the program. So I hope all of you will punch in questions as they come along, especially for the first speaker, who will be addressing the issue of post-mortem COVID-19. The usual logistics and the rules and regulations of the webinar remain the same. So I have chosen not to repeat them. I think many of you are veterans. You know where to put your Q&A, where you get your CPD points, and everything is up there. You can read it yourself. So let me first introduce our speakers, and I'll introduce them one by one as they come to the mic. As I mentioned just now, we will start off in the issue of postmortem in COVID-19. And to address that issue for us is Dr.Ahmad Hafizam Hasmi. He is a forensic medicine specialist at the National Institute of Forensic Medicine at Hospital Kwok. He has undergone advanced competency program in forensic pathology at the Victorian Institute of Forensic Medicine at Melbourne, Australia in 2019. We had the privilege of listening to Dr. Hafizam a couple of weeks ago before Raya by the National Mortality Committee on COVID-19, and we had the opportunity to listen to some of his findings on four very interesting cases. And he certainly made our work at the National Mortality Committee much more fruitful and enlightening. So without further ado, I'm going to ask Ahmad Hafizam to start off today's proceedings. Hafizam, you have the floor.
Assalamualaikum and good morning, everybody. Thank you to Datuk Dr. Christopher. I would like to thank Institute of Clinical Research for inviting me and National Institute of Forensic Medicine to participate in this particular webinar today. Assalamualaikum, good morning. Can everybody hear me clearly?
Yes, we can hear you. Can you share your screen now? Your slides.
Assalamualaikum, good morning. Today, I'm going to share with everybody on high-risk autopsy on COVID-19 that we perform in Hospital Kuala Lumpur. Okay, this is the outline of the presentation for today. Number one, we're going to define the high-risk autopsy. Number two, requirement for the high-risk autopsy to be done. Number three, the post-mortem finding in COVID-19. And number four, conclusion. So what is the definition for high-risk autopsy? The definition for high-risk autopsy is post-mortem examination or an autopsy of a decedent who had or is likely to have had a serious infectious diseases that can be transmitted to those present at the autopsy, thereby causing them serious illness and or premature death. This include hazard group 3 pathogens such as what we are talking right now, COVID-19. So what is the requirement for high-risk autopsy? In general, the requirement of a high-risk autopsy evolve around, number one, risk assessment. Number two, understanding the pathology. Number three, universal standard precaution. And number four, standard operating procedure for specific hazard group 3. In Hospital Kuala Lumpur, the requirement to perform high-risk autopsy resolve around, number one, legal authorization of that particular autopsy. Number two, planning and protocol for that particular autopsy. Number three, we need to have a fully trained team to conduct the autopsy. Number four, a proper equipment to conduct that particular autopsy. Number five, a proper facility to conduct that particular high-risk autopsy in terms of biosafety level 3. And number six that we have in Hospital Kuala Lumpur is an added to guide us to perform this particular autopsy is post-mortem CT scan facilities. Okay. In Malaysia, the death investigation around post-mortem or for post-mortem examination can be done either under the Criminal Procedure Code or under Prevention and Control of Infectious Disease Act or Act 342. For legal purposes, criminal legal purposes, the post-mortem examination been ordered by the authority, i.e. the investigating police officer under Criminal Procedure Code. Whereas if that particular issue resolves around public health issue, the post-mortem examination been ordered by health authority under Prevention and Control of Infectious Disease Act, Act 1988. Under Section 16, Act 342, for post-mortem examination order, whenever an authorized officer suspects that a person has died of an infectious disease, he may order the corpse to be conveyed to such place as he may appoint for such examination as he may consider necessary. The objective of COVID-19 autopsy under Section 16, Act 342, number one, to address public health issues, that means prevention and control. Number two, to better understand the pathology of COVID-19. And number three, to guide clinicians in terms of treatment. With this particular legal authorization, there is no requirement of consent from the family member to conduct this particular postmortem. This particular postmortem fall under legal postmortem. In HKL, there are 16 positive COVID-19 cases. There are 16 cases that died in the hospital for COVID-19. And from this particular 16 cases, we perform 4 cases under Prevention and Control of Infectious Disease Act. Okay. Before we conduct that particular post-mortem examination, we do a proper planning and devise the protocol for that particular post-mortem examination to be done. We set up a trained post-mortem team. This particular post-mortem team comprised of 4 or 5 team members that include of forensic pathologist, forensic registrar, and also forensic technician. In this particular team, we assign a person to become a clean person. She or he going to become the one who going to document the post-mortem examination, and he or she going to handle all the post-mortem specimen inside the post-mortem room. We also assign a dedicated support team to assist in the postmortem examination. This particular support team the responsibility of the support team, number one, is to check all the PPE that going to be used by the postmortem team. Number two, they are the one who going to handle all the specimens from the postmortem room. Number three, they are the one who going to supervise the donning and doffing aspect of the postmortem team members. And number four, the support team also, one of the member of the support team also going to become the backup member if any eventuality happens in the postmortem room. For the postmortem team members, they're going to wear a full PPE level 3 together with PAPR. PAPR stands for Power Air Purifying Respirator. So in this particular picture, we can see the support team member calibrating the PAPR that's going to be used by the postmortem team member. This particular picture showed a postmortem team member with level 3 PPE together with PAPR. Okay. This is our biosafety level 3 postmortem room in Hospital Kuala Lumpur. This particular postmortem room equipped with negative pressure room, HEPA filter, pass-through body freezer, high definition CCTV, and also a pass-through chamber for the specimens. This is the viewing window for observant that can observe the postmortem examination. And we have high definition CCTV inside the postmortem room, and that particular postmortem being recorded live. This is our technician, this is our scientific officer handling the aspect of recording of the postmortem examination. High-risk autopsy such as COVID-19, it is new emergent diseases. So there are a lot of specimens to be taken during postmortem examination. It is to make sure that that particular postmortem been done optimally to answer all the medical questions. So the one who going to handle this particular specimen need to be diligent because she or he going to handle a lot of biological specimens. Okay. This is one of the method. Even though we perform this particular postmortem inside biosafety level 3 postmortem room with negative pressure, there are still a risk doing aerosolized procedures such as postmortem craniotomy. In Hospital Kuala Lumpur, we devised a craniotomy box to protect the operator during the postmortem craniotomy. This particular craniotomy box is being made by a transparent plastic, and this particular method protect the operator from the dust that being produced by postmortem craniotomy procedure. So what is the postmortem finding for COVID-19? In general, from the other literature, the postmortem features of COVID-19 as widely reported: number one, diffuse alveolar damage; number two, severe endothelial injury; number three, presence of intracellular virus; and number four, widespread thrombus and microangiopathy. Dr. Eric Topol from US already made a systematic literature review through Twitter regarding the finding of the postmortem examination that been recorded from different countries. Since this particular disease is a new disease, a proper systematic literature review need to be done to compare the finding of the postmortem from all respective center. Okay. So what is our experience in Hospital Kuala Lumpur? We perform 4 postmortem cases in which 3 are males and 1 female deceased person. The age ranged from 65 years old to 77 years old, and the duration of admission between 7 to 17 days. All the case having one or more comorbid, and the comorbid are diabetes mellitus, ischemic heart disease, hypertension, chronic kidney disease, and the other one having laryngeal CA. The stage of admission for COVID-19 range from stage 3 to stage 4. The postmortem finding that we saw during the postmortem, number one, we can confirm that that particular disease person having the reported comorbid disease. Number two, we can see the spectrum of pneumonia from mild pneumonia to severe pneumonia. The COD that been given from this particular slide is a clinical COD that been given by the respective physician who treat the patient. Okay. Case number one. This particular gentleman having multi-organ failure, and from this particular picture, he was severely jaundiced, indicate that he's having liver failure. Okay. Examination of the heart showed dusky appearance of the epicardium. Cut section of the heart do not show any sign of acute or remote infarct, and there is a postmortem clot inside the chambers of the heart. Histology of the heart showed infiltration of a lymphocyte over the epicardium of the heart. However, there is no myocarditis seen. Examination of the respiratory system showed there is presence of fluid inside the trachea and bronchus. The fluid yellowish in color and not sticky. Cut sections of the lung showed red hepatization of the lung and iris consolidated and unhealthy appearance, whereas in the other picture showed a normal lungs appearance. Cut section of the lung also showed presence of mucus plug inside the small airways. Okay. Histology of the lung showed hyaline membrane formation consistent with diffuse alveolar damage. High power showed presence of cytopathogenic effect of viral pneumonia of the lung tissues. And in some area, there are superimposed bacterial infection in which we can see a lot of neutrophil infiltration in the lung tissues. From our postmortem finding, we did not detect any. We failed to detect a thrombus inside the vessels. This one showed a blood clot. It is not a antemortem thrombus. For case 2, case 2 is a lady having coronary artery disease. So postmortem examination shows that atherosclerotic changes of the coronary artery, and on cut section of the coronary artery, it showed that it is totally occluded by the atherosclerosis changes. Cut section of the heart showed dilated chambers with patchy fibrosis, and then histology showed evidence of fibrosis of the myocardium. Examination of the airways showed pattern airways with minimal fluid inside the airways, not like the previous case or case number 1. Examination of the lung showed the pneumonic changes confined to the lower lobe of the lung, whereas the upper lobe still showed aerated lung. Histology of the lung showed infiltration of neutrophils into the interstitial and alveolar spaces, but for this particular case, no obvious cytopathic effect detected from the tissues. Examination of the kidney for this particular case showed confirmed that this particular lady having chronic kidney disease. For this particular 2 cases, we do sample the tissue for RT-PCR. We do sample tissue for COVID-19 RT-PCR. For case 1, we do sample postmortem nasopharyngeal swab, and it is detected for both cases. The trachea swab also showed COVID-19 antigen detected for 2 cases. Oropharyngeal swab also detected for 2 cases. Bronchial swab detected for 2 cases. Body surface swab, the antigen also detected for both cases. The swab from the mouth been taken only for the case 2 and it is detected. Swab around the nose also been taken for the case number 2, detected. We also swab the ear canal and the antigen been detected. We took vaginal swab, the antigen detected. We swab the lower limb surface and the antigen been detected. The antigen been detected in the serum. The antigen also been detected in the vitreous humor of the second case. The antigen been detected in the second case of the antigen been detected in the pericardial fluid for the second case, but not for the first case. And for pleural fluid also, the antigen not detected in the first case, whereas it not been taken for the second case. The antigen been detected in the urine for the first case and been detected in the feces for both cases. The antigen also been detected in the ascites fluid for the first case, but not in the second case. The lung tissue, we detect the antigen for the second case, but not in the first case. We detect the antigen in the heart tissue for both cases. We detect the antigen in the kidney tissue for only the second cases. Adrenal tissue for the second cases, because the first cases we do not take the adrenal tissue. We detect the antigen in the liver tissue for the second cases, the spleen in the second cases, in the lymph node for both cases, and in thyroid only for the second cases. So what is our next step? Our next step, looking at these particular issues, we think that we need to explore other pathology diagnostic modality to detect the changes due to COVID-19 from the paraffin block tissues. So what we're going to do is we need to send the tissues sample that we already fixed in the formalin and already in block to a center that can do more pathologic diagnostic work to assist us in understanding the pathology due to COVID-19. So in conclusion, we perform high-risk autopsy number 1 to aid in the current understanding of pathology of COVID-19. Number 2, to provide valuable information to determine whether the death was direct or indirect result of COVID-19. And number 3, the need to develop capacity and capability of forensic services to deal with any future pandemic. Now, this is the reference for this particular presentation today. And I would like to thank the listed person in order for me to come up with this particular presentation. With that, thank you.
Thank you, Hafizam. Thank you very much. I'm sure there are questions, but we will have to put the questions at the end. So for all of you who want to ask questions, please start putting it down onto paper or put it onto the Slido, and we'll look at the questions later when we have a Q&A session collectively. So Hafizam, thank you very much. You can sit back and relax first until the end of until the Q&A starts. Thank you very much. Okay, now we're going to move gears a little bit and move on to the issue of mental health. So put aside the postmortem now, okay? Now, to look at the mental health issues, we have 3 experts looking at different areas of mental health in the country, and I will introduce them one by one. And obviously, they will look at different aspects of this wide, big area of mental health during the pandemic. I think a lot have been written about this in a lot of literature overseas. But I think in our country, we are certainly a bit behind in terms of documenting these issues. First, let me introduce Esther, correct? Esther Teo Siang Ching. She is the president of the National Council of Befrienders. No, I haven't seen. Yeah. Okay. It's in which one is it?
You might just press it.
You wrote a lot somewhere, is it? Sorry, sorry, we are looking at different handphones that you have. All right. Okay, thank you for the technical support, Ching Hoon and Dr. Goh. The screen just disappeared. Esther, just bear with us for a while. We want to make sure we give you the right introduction, all right? Dr. Goh is an excellent director of ICR, but technically she's not very good when it comes to technical support. Now, Esther Teo Siang Ching is the president of the National Council of Befrienders in Malaysia. As a potential befriender, she was given a full year's training in 2007 in this area. After that, she pledged herself to be a befriender in 2008. She has since been serving in the EXCO of both Befrienders JB and at the National Council of Befrienders. She is also one of the past chairperson of Befrienders JB and 6 years as a vice president in the National Council. And she has been the chair since 2016. So obviously she's very experienced in providing mental health support at the community level. I'm sure we will learn a lot from her perspective. So Esther, welcome again to the webinar. You have the floor.
Okay. Good afternoon. Good afternoon, everyone, and thank you. So I straight come to Befrienders Worldwide. Befrienders Worldwide, what are we doing? What our Befrienders Centers offer and how they operate are summarized in a statement called the 8-Point Charter. And it was started in England, 1953, by Reverend Chakvara. The Befrienders Center, from point number 5 of the 8-Point Charter, the Befrienders Centers are non-political and non-sectarian, and the volunteers do not seek to impose their own convictions on anyone. Now in 45 countries, 500 centers, and the number is keep on increasing proportionally to the demand of our communities worldwide. Yeah? And as mental health issues, we know that it affects much younger age nowadays. And our volunteers offer the 3 A's and 1 C. That is the anonymity. Anonymity is both to both parties. Volunteers and callers do not need to give their names as per their identity card. They don't have to give their true names. And availability remains service hours offered by each center. For example, Befrienders Seremban, they offer their service from 7 p.m. to 10 p.m. daily throughout the year with no holidays. And the same go to Befrienders Care, offer 24 hours and no holiday too. Yeah, every center will be the same, but their service hours are different. And for acceptance wise, we mean in befriending, we mean accept every caller for who they are. We are being non-judgmental. We separate the being and the doing. Every caller to us is the same, although we might not like or in favor of their doing, of what they are doing. Then confidentiality actually is our trademark. From point 4 of our 8-Point Charter, it stated the fact that someone has been in contact with a center, whether by telephone, letter, visit, or any other means, is confidential. So too is everything revealed by or about the person. Befrienders Malaysia started in 1970, started in KL. Yeah, and now we have 9 centers: Kuala Lumpur, Penang, Ipoh, Melaka, Seremban, Johor Bahru, Kota Kinabalu, Muar, and Kuching. Kuching is started in 2018 and now it's going to 2 years old soon. For Kuala Lumpur, already 50 years. So these there are some volunteers, more than 50, about 50 years, in 50 years in befriending service. And to name one of them is our national advisor, Mr. Ganganara. Yeah, he's with Befrienders KL. If without this MCO, we will have formed Terengganu. We will have one Befrienders Terengganu, but because of this MCO, we have to hold on. And we are very grateful to have professionals like Dr. Rohayati Muda, Dr. Lim Po Kwan, and a popular Cikgu Muhammad Hasmi, who helps to initiate this forthcoming project in Terengganu. And we are looking towards it. When we come to this table of services, this table of services is for MCO period. Yeah. Before the MCO, our normal befriending services are through phones, emails, WhatsApps, and face-to-face befriending. But during MCO, we have to do some adjustment. So during MCO, some centers are totally unable to operate as they are situated in the red zone area of the COVID-19. So every center try their very best to adjust and adapt to new modes of befriendings so as to be accessible and available to the callers. So we have services like this, Skype, WhatsApp. These are temporary services, yeah. And the phone number here is also for the temporary use. Yeah? And we can have all these. We like to thanks to our Malaysian Communications and Multimedia Commission, MCMC, the eight companies shown here who have collectively and generously offer free calls from the public to all the befrienders, yeah, to all befriender centers in Malaysia. This offer gives a great relief for the callers, a great relief financially to the needed callers. One of the reasons is a caller might not only call one time, they call many times and they even become a regular caller. So for this statistic, before normally I take it from one center because I stationed in Befrienders Johor Bahru. So I take it from Befrienders Johor Bahru. In last year, we have 356 in March, the number of calls for the month. And April, we have 371, and May, we have 430. This number is only through phones, excluding the other modes of befriending. So 9 centers, I average out is 3,000 plus, 3,000 to 4,000. During MCO, the figures are almost double, or more than double. Because MCO period really needs a lot, and our volunteers have to work harder. So befriending services during MCO, CMCO, what's the difference? We still based on our 3 A's and 1 C, but it's a great difference now, in a way that anonymity and confidentiality is almost still the same, no change. But for acceptance and availability, I have to speak about this. So for acceptance, not only callers, we befrienders have to accept the situations and have to adjust accordingly, so as to have our centers being accessible and available to the callers. That's why just now I showed the table is a modes of befriending also change, mostly online. And come to these different types of caller. Yes, there are many different types of caller. Before that, I come to availability. I'm very grateful to all our 9 centers. Work very hard to find new ways and new methods to ensure their service are available. And our volunteers also, numbers of volunteers, some volunteers cannot come over because our family members get worried. So we also reduce our number of volunteers, and also to abide to the rules, to the SOP that social distancing. So we also reduce our number of volunteers. And we come to these new issues or topics shared by callers. During this time, we face is mostly they have this new issue is family conflicts. Family conflicts are parents, in-laws, and siblings. Because normally when before MCO, they are able to go out. They have their own space, and now they are all locked in a house under the same roof. So the space, and they haven't get to this, so they have this conflict. And this conflict is rather serious. Some are rather serious. And number two is like jobs wise also an issue. They have no income. Some they said they lost their job. Some they have a stable job to cover up, but now suddenly they have no more income. And number three is like well-being also affected. Their anxiety. They are so anxious. They call up. They say their anxiety level is increasing. Before that, they say actually he also suffer from anxiety, but now it's getting serious. And issue 4, I can find that is like time when they have a doctor appointment. They find that doctor appointment, they are not able to go. They're a bit worried, but when the time comes, they are able to go to the hospital. They find that it's rather time consuming and rather inconvenient. And when they reach the hospital, they met the doctor. The doctor seems the doctor seems don't have much time to be with them. So they hurriedly take the medicine and come back. So they call up befrienders to talk about it. But anyhow, they feel happy to have done their part, to have made the appointment. And they feel good after talking to befrienders is that anything they feel not so comfortable, they can just talk to befrienders. Some now online, now during MCO, there are many professional counseling line on for accessible for callers. And they also try out, and they find that the feedback from them is very good and very informative. And they call up befrienders. So I just wonder why. I asked him. He said, now you're very happy. He said, yes, I'm very happy, but I still call befrienders is because to professional, they have to like more quoted as like well-behaved. To befrienders, they find that they can talk more easily. So there is some issues of this from the callers. And one of it is the festive season issue. Festive season issue is started from like Cheng Ming. Most cannot go to the graveyard place to have prayers or to temples. So, but they still can. Although they ventilate a bit, but they not that affected. And for the Hari Raya and for all this festive season that they cannot go back. They cannot go back home. They have to stay alone, or some they did manage. But most of them, they can get over it. They can get over it because they can still, I told them, I mean, you are not alone. You can call. And then there are many helplines also beside befrienders. So in Malaysia, they are all rather lucky. And come to this, I find that the unique findings for this, the different states of mind from the callers before MCO and during MCO is most callers are anxious and they are more doubtful, concern their strength of sustainability. They find that now they can, like firstly starting MCO, they find that at the moment they still can get excited, but after the MCO keep on extending, they doubt their sustainability ability. They wonder they can cope or not. And for this befrienders, we are trained volunteers, and some doctors and psychiatrist professionals are also join us as befrienders. And from our 8-point charter number 7, centers may, on certain requests, the advice of professional consultants. So befrienders are always working with professionals, doctors all. And for number 8, in appropriate circumstances, callers may be invited to consider seeking professional help in addition to the support offered by a center. That's why we have in our center, in every center, we have a reference book. And in the reference book, we have professionals contact. Because sometimes we find that some part that we really can't, not only the emotional support that we can give, we will advise them. I mean, we will give them the option to seek professionals' help, and we give them the contact. So, for example, in Befrienders JB, we have Dr. Siva, Dr. Benjamin Chan, and Dr. Abdul Qadir as our consultants. And Dr. Abdul Qadir is also one of our national advisors. So from here, I really hope that doctors from all professionals in the health departments can join Befrienders or can work together with Befrienders for the well-being of our community. Yeah, with this, I thank you.
Thank you very much, Esther. Thank you very much. I'm sure there are a lot of questions for you later on. I'm a bit suspicious now. As the MCO went on, my wife kept asking me to go to work. So maybe I'm the stress at home for her. Don't tell her, okay. But maybe if my wife might want to ask questions afterwards too. Now, so Esther, hold on. Thank you very much. We will move on to the next speaker first and address your questions collectively afterwards. Next up, we have Dr. Ahmad Rostam bin Muhammad Zain. He's the consultant licensed psychiatrist at the Sultanah, Hospital Sultanah Bahiyah in Rostam. He will talk about the mental health demons and how to overcome the challenges ahead. I'm pretty interested in this because I've got tons of demons inside there. So I saw you just now, Ahmad Rostam. You are ready?
He's ready.
He's ready? Oh,
yes, I'm ready.
Okay.
Yeah.
You have the floor.
Okay. Thank you so much, Dr. Chris, for the opportunity to talk. So I have a very interesting topic to discuss today, but I have 15 minutes. I will make it very short, and to make sure that everyone of you out there understand what's actually the salient point for us to cater when we are dealing with our patient and client when they come to our clinic. So when we are talking about COVID-19, we are talking about a storm, an unusual storm, something that all of us has never experienced before, that caused lots of problems to all of us, regardless of how we see it. So from our point of view, it's actually very interesting to say that every single one of us perceive this storm differently, and we are having problems to really making sense of what actually happening, because no one has experienced it before, as I said, right? So moving forward, when we talk about this COVID-19 and PKP and also PKPB and everything, we are talking about loss. So all of our clients, all of our patients that come to us, they have lost something during this period of COVID-19, whether it's about their freedom, whether it's about their connection with people, whether it's about opportunities, whether it's about income, job, health, and lots of things. So every single one of our patients and clients is actually very special in their own sense, and they are we to have our really have to have our ear to listen properly what's actually they are trying to bring forward, because as I said, every single one of them is special. So if you are trying to make sense about all this loss, because if I'm talking about the loss, actually lots of things. There are people that's actually having the COVID-19 infection by themselves. There are quarantine people. There are people that need to be away from their family. There are people that is actually not allowed to come to see their patient, their family that is sick. And there are so many problems. Every single one of them is actually important to their point of view. But maybe for us, it's actually very small things. But if you go through all the cases that we have been seeing while we are covering during this period of COVID-19, we can see that lots of patients that comes to us presented with lots of anxieties, because we know that this is a period of uncertainties. So period of uncertainties cause lots of anxieties because people don't know how to handle, people don't know how to face this properly, and people at the same time people are losing a lot of things. So there is a psychological process that's going through the minds of our patient and client. And what we call this is actually a process of grieving or bereavement. And I would like to present to you a process of bereavement that's actually introduced by Kubler-Ross many years ago, which involves 5 stages. Number 1 is shock. Number 2, anger. Number 3 is bargaining. Number 4, depression. And number 5 is not included in the slide, which is acceptance. And that is actually what we are trying to bring our patient to, which is accepting the fact that we are going through a very difficult period, which is COVID-19. So if we see our patient, including our frontliners, they are going through all these stages of grief. There are lots of people show their shock, their anger. They are trying to bargain with the authorities. They are trying to bargain with the doctors. They are trying to bargain with everyone to get things that they think is very important for themselves, even though they know that it's not, it's dangerous. For example, I can give you, it's actually people who are trying to cross state, even though the ministry already tell us that you cannot cross states. For me, it's actually one of the stages of grief or bereavement that people are going through. They are trying to make sense of what's actually happening. They are trying to make things more normal for them in this period of abnormalities for everyone, even for us too. So when we see our patient or our client, it's actually we are seeing people who are going through grief properly. So how to handle them is actually our ability to really listen to what actually they are telling us. So how we want to recognize this is actually by going through what kind of loss they are going through. So I already listed out there different domains of loss that people can go through, and we can check on ourselves that we also experience certain kind of loss during this COVID-19 period. So when we are talking about grieving, when we're talking about loss and everything, there will be a breaking point for everyone, because we don't know our mental fortitude. We don't know the level of strength that we have, resilience that we have. And we must remember that every single one of us has a different mental fortitude or their defense psychological that they have. So every one of us has their own breaking points, whether it's actually external breaking points or internal breaking points. When I say about external breaking points, it can be about the social support that they have at home, because many of us out there, we live with the family or friends or someone very close to us. So all this is actually the social support that we have. But we must remember that during the PKP, especially during PKP, many people cannot move outside from their home. And what happens actually, they are living with their a broken social support in their home, in their vicinity. And that's actually a kind of stress to themselves. So for many of us, we think that if you are staying at home, you must be happy. But there are a small amount of a small part of us that especially not happy staying at home, and they need to go to work and they need to go out, because house or their home is actually the source of their stress or pressure. And then we must remember that aside from the breaking points of social support, we are talking about other external factors such as job or opportunities or income or the social service that they get when they are going through PKP and everything. So all of these can be the point where our patient or our client breaks. And on top of that, we have our own internal defense or psychological defense and everything, which is some some of it, such as our coping styles, is totally different. There are people that have what we call as abnormal or inappropriate coping style, such as they are using substances, they smoke a lot, they use drugs, or they do things that's more dangerous, such as overeating themselves, not doing anything at home, and they can be people who cope through anger, which is very dangerous. And that's why we notice that there are reports who say that domestic violence is increasing during the PKP period, because of there are people who cannot cope properly, and they are venting their anger and everything towards the loved one, which is at home in front of their eyes and everything. So, and on top of that, we have other internal coping, or which is our spirituality, our personality traits, and other things that essentially help us to really hold on during the storm. But unfortunately, not all of us can really sustain the pressure that we have after months of inactivities, after months of PKPs, after months of no income, after months of pressure from outside the home and outside. So all of this can make people break. So what happens actually when people break? There are a few symptoms that they can present to us. Number one is actually psychological symptoms, which is totally, I would say that many of us can really cater, or we can really identify. Number one, anxieties. Anxiety is essentially the most common presentation to all of us, even among our frontliners, in which they come with their worries about getting themselves infected with the COVID-19. They are worried about the health of their family members outside. They are worried about everyone. They are worried about strangers. They are worried about their daughters, their children, everything, everyone. So that is one of the most common. Even essentially one of the review paper that I've read through, they say that anxiety is actually the most common psychological manifestation in the COVID-19 episode. And as I told you just now about the process of grief and bereavement, we are talking about different kind of psychological presentation. Aside from the anxieties, we have anger problems. We have bargaining, which is people can bargain in a good way or a bad way. And there are people who go through a episode of depression. And especially this point of depression is very important in the sense that we must remember that lots of people that need to stay at home, they are having that pressure on their own. And especially the most important group is actually among our postpartum ladies, postpartum mothers, in which they don't have the kind of support that they have before. Before this, maybe after a mother delivered their child, they have lots of visitors, they have lots of help outside. But now they need to be alone at their home with their husband that may be working outside, and they don't have the support that they have. So this can also worsen their depressive symptoms and everything. So I don't say that it actually can cause increase of the incidence of postpartum depression, but it can increase the risk of postpartum depression. So how we want to help our client or our patient that come to us with all these kind of issues? As I said just now, number one is actually our ability to identify what kind of losses that they have gone through. So that is the most important thing, because once we are able to listen to their loss, we are actually able to empathize with them, able to gauge what is their problems, and at the same time, by able to listen and empathize, it's actually helpful for most of our patients. They don't want our advice most of the time. They want our ears to listen to what is actually their difficulties. Number one, identify. Number two, empathize. And then number three is actually our ability to offer what we call as low intensity psychotherapy or psychoeducation. What do I mean by psychotherapy? Is actually supportive psychotherapy. Supportive psychotherapy does not need you to train yourself for a certain specific kind of psychotherapy. It's actually the ability to listen and the ability to reciprocate back to our patient, the ability to reciprocate back to our client about what is actually they are trying to tell us. Because when people know that they are being understood, they are more open to be better in a sense. Most of our patients that come to us does not really need medication, but they need the psychological support, which is actually psychotherapy or supportive psychotherapy, or in a layman's term, I would say that talk therapy. So, aside from that, of course, when we know what are the losses, we can help them to build up certain kind of resilience, because resilience is very important in these very trial times, right? So how to able to really control their anger. So as I said just now, anger management is one of the big issues during the PKP. How to help them to manage the anger properly, how to help them to manage their negative emotion properly, how to help them to make a better decision rather than we give the decision to them. So all of these things, even though it's actually very small, very minute, it's actually very important to our customers and to our clients and to our patients. So I would say that that's the few things that pertinent to us, the frontliners, to help our patient in this trial time. With that, I thank you.
Okay, thank you very much, Rostam. Thank you. I think you brought up many issues that I think would explain some of the experiences that Esther spoke about earlier. Clearly, I think the pressure on the community at large is significant. I think one major factor, obviously, in terms of loss would be loss of income. And being a clinician, even in the last 2 months when I bumped into old patients at the hospital, whenever we talk about how are things with you, they are not as worried about their health. I guess they come to collect their medicines, they are reasonably okay. But most of them will always bring up the fact that they are worried about whether next month they can pay the rent for the house and whether there will be food on the table. Of course, in the public hospitals, we are looking at those group of patients who probably are not earning as well as those in the private sector. So clearly, I think that's one of the main areas. You also alluded to the fact about the stress and the mental pressure on healthcare providers, and I think that's extremely real. So I think we're going to move on to the third speaker, and it's a bit of a stress for me, and I must thank Dr. Ravi for informing the Secretariat that I may not need to pronounce his full name. But I'm a man who likes to live dangerously. I'm going to pronounce your name exactly as it is. So I'm going to introduce Dr. Ravivarma Rao Panirselvam. Did I get it right?
Yeah, that's kind of it.
Kind of right, yeah. Oh dear, I'm going to try it again. Dr. Ravivarma Rao Panirselvam. Okay, I assume it's right. Okay, from Hospital Miri. Okay, Dr. Ravi, thank you very much. And he will be talking about the psychological impact or psychological issues on healthcare workers. And as somebody who has worked on the front lines before, and I think especially during SARS about nearly 20 years ago, I totally identify with this. So Ravi, you have the floor.
All right. Thank you, Datuk Chris, and hello everybody. Let's get this. Started. All right. Okay. Can you guys see the screen first? Just would like to be sure of that.
Yes, we can. We can.
All right. So thank you so much for this opportunity and to talk about what happens to healthcare workers. It's actually sort of like a catch-22 situation. We can't actually go anywhere from this because while others stay at home, we have to stay at work. That invariably puts us at a much higher risk compared to anyone else.
Ravi, we need you to share your slides.
It's not big.
Now it's in presenter view.
Oh, it's sharing presenter view, is it?
Correct,
all right.
correct. Yes.
Okay, then you get to see all my notes. Hold on. Let me adjust that.
We are good now. Right.
Is it okay?
Yep.
All right. Okay. So while the others actually sort of had to stay at home, we had to go to work, and that puts us at an increased risk. You meet people, you meet clients, and of course you meet people who actually may be harboring the virus. So that is a unique situation, and I have to thank Dr. Rostam and Madam Esther for setting the stage. So I might not need to explain that much on what we can actually anticipate. So this talk, this 15 minutes or so, I'll be just talking about how healthcare workers are affected, why they could be possibly affected that way, and more importantly, I think I'll spend more time in explaining what we can do to help healthcare workers as a whole. All right, and rather oxymoron, where most of these effects are very much masked. You might not actually see it in your healthcare provider, whether you're seeing someone or whether among your colleagues. But after lots of work that's been done, this is just papers that were surrounding the COVID-19 pandemic. We are affected directly or indirectly, and the common emotions and the situations that we are affected is distress, depression, anxiety, and insomnia. They range between 20 to 30 or so % of the groups of people when they're tested. The depressive symptoms, they might not be disorders. The data, the preliminary data we have in our country also sits around this area as well. So why does this happen? Mainly, there's a lot of exhaustion that goes around. It's where not just it's not just work. It's not just usual work. It's usual work plus extra work. The availability and inavailability of PPE is an exhausting thing, and the way we have to change our work is also it can also exhaust us, especially in the terms of that some of our services are going online and all of that. And the media enthusiasm in reporting things like healthcare worker clusters and the difficulties sometimes is very much unhelpful. And besides all of this, the whole fear of being infected and the fear of infecting others, that affects us. And the stigma that we suffer because we work in healthcare. I think in Singapore, I think there were a few newspaper articles and people who were going in, were shunned away from public transport, etc. And there is an element of moral injury, and that moral injury that came very early on in the pandemic that was reported in the BMJ. It's that what is the fact that we have to do something that which does not be that is not consistent with our ethics as well, with the way our what we will be usually treating. And most of the times this happens at various degrees. At some places it's at some places in the world where they're not so prepared for the pandemic, it's much worse. But sometimes even seeing a client on a regular basis, like for myself, if I see someone who has probably a neurocognitive disorder or dementia, I can't be prescribing the usual OT and the usual methods of treatment as because of the whole policy of physical distancing, etc. So that's that. And of course, support, the level of support the person, a healthcare worker, has got from the beginning and how it has progressed, especially during and even after the pandemic, also determines how the distress or how the psychological response will sort of be. And there are many factors that affect this, and researchers and people who have studied this have examined the socio-demographic factors, age, gender, and of course the different reasons. If you're much older or someone who's not used to, or if you're much younger or lacking experience, it goes both ways. If you're younger, you might have not lived through the SARS the SARS epidemic time, so that would mean you have less resilience in handling a pandemic. So in Singapore, those who have actually gone through the SARS episode, they were found to be more resilient compared to those people who are just coming new onto this. And also where you're working, you could be someone who's working in the front line, someone who could be actually working in other departments, and that also affects how you respond to it. Sometimes we tend to believe that, just if you're working in the thick of it, you're a front line, you're seeing patients with COVID, that's when you'll be mostly stressed. But when Lee and colleagues in China actually did this work on vicarious traumatization, they actually found that the group that was not in the front line, or the support group people, which I like to call them the penumbra group, the often forgotten other department staff, they were actually found to be more stressed because probably because support doesn't reach them, and actually they're picking up a lot of workload. When we had to deploy people into the COVID wards, the rest of the work did not actually reduce. It was just that for less number of people to do so, and that too. And when are you at the pandemic, and where are you at that time? Meaning at the early of the pandemic or middle, or what's the situation in your hospital? Time matters here as well. And how supported were you before? and situations at home, geopolitical, social situations, your financial situations, all also affect your response and why are you at a particular place. Sometimes people are being sort of ordered to work at certain places and they're not actually going willingly, and that can itself is sort of a distress that can form on them. So if to say what affects you, it really matters where you are, and it's like riding a wave. Sometimes you're very affected, sometimes you're less affected. Knowing all this is quite important because it will help us recognize and also to help us deal with these challenges as well. Recognition is sometimes quite difficult because sometimes we ourselves are not aware of our own challenges in some or whether we are in distress, and it'll come in a bit in the next couple of slides. And if you know someone is having distress, what do you do? Do you straight away bring them to a psychiatrist? Do you what kind of help do you do? So there's a spectrum of challenges and the help that people need in this process. And sometimes people can also recognize when they can do some self-report, and that actually sort of helps as well. So this is something that when I was preparing for this, I spoke to one of my friends who's working in a COVID-19 ward, not my hospital, a different one. She said this, actually, she said that it's not managing COVID that is hard, it's managing the responses and the fear that comes about it, and the subsequent unhelpful responses that come. That's really what shows that really underpins the importance of the reason we are doing this topic and why we must support people and help them through their distress. And healthcare workers fall into this trap often. They think that they have to give all, do all. This is actually a marathon, and in order to get out of this or get through this, we really need to look after ourselves. So look out ourselves and look after our colleagues as well. So we can't technically be very self-sacrificial as well. So in that context, I organized this part into what we can do for ourselves, the people around us, and most importantly, what organizations can do. And I mean organizations, they can mean the hospital, the department, as well as your GP setup, your local pharmacy, anywhere that goes, and finally a bit about the system. And if we look at the way we respond to psychological issues with regards to COVID, predominantly what we have found by experience locally, as well as with fellow colleagues and as well as literature, say it's not really just if you have psychological distress to see a mental health professional. There's a lot of other things that you probably would want to do that actually seems to work much better. So let's start with self. We as healthcare workers need to realize that being stressed is not a sign of weakness. You're going through, if you want to look at it as a good analogy, it's like driving a car on top of a hill. You're going to put in more petrol. You need more fuel. You might need to recharge a bit. You need to go so that whole idea that this is a difficult time, that acceptance of that, it really sort of helps. So then you start looking after yourself, your needs. Taking breaks is okay. Staying connected with friends. Communicating your distress and communicating your unhappiness, that's actually an art that we fail to do. Sometimes we stay quiet in reasons of being polite, and then something keeps happening and irritating us. But also there's also the other extreme where we lash out, and actually by lashing out, we actually hurt ourselves. So constructive communication is something that we do need to be mindful and you need to learn about, and it's quite helpful. And wherever you are in the healthcare spectrum, wherever you do work, you can be an attendant, you can be pharmacist, you can be working in the eye clinic, wherever you are, your work matters at this moment. I think honoring your service and accepting that you are important at this point is actually one of those best that we can do for ourselves, because we all form part of the puzzle that actually helps us to solve and get through this pandemic. And at that same time, we also need to accept and also respect the differences that people may go through in coping. And from time to time, at least in a day or just check in with yourself whether you're doing okay, and get help. It's okay to get help, and I'll talk a bit about that when we come to the organizations bit. And while we're looking after ourselves, it's also important to keep an eye on our fellow colleagues, people around us, actively checking in. You might want to use technology for this. And also talking about getting help and also helping people get help is often something useful. Asking, are you okay, now can be very, very valuable. And now coming to the bigger bit of it, what organizations can do. So we have talked about self-care, we've talked about care for others. Organizations need to facilitate that these things actually happen, and they can do it in two ways. One is a structure of psychosocial support, which I'll talk a small bit, but more importantly, how equipped, and continuously we go on to getting ourselves equipped in facing the pandemic is actually important. We need to build a sense of safety. People need to feel safe to come to work. People need to be communicated well, and that is one of those things that matter. This is some things that we have done in Miri, which basically we need to look at every aspect of how we work, how our policies work. You might need to revise policies. You need to make sure that they're clear and they're comprehensive. They do need to cover every small, tiny details. You can't say, okay, do phone consultation, and you don't actually tell how to do it. You don't even have phones. So you got to really spell those things out. And then when you are trying to build policies, it's important as people who write or people who make decisions, you actually go down to the grassroots and actually listen. And listening is not just hearing, as this nice caricature. I've sort of like found this online. I remember this from a talk a few years ago on how to listen. And it's also important for us to, when we communicate, we have to be really sure whether that communication has happened. The biggest problem is we live in this illusion as though it has happened. As though, okay, people have understood that you have given a set of instructions, and okay, we have sort of understand. Sort of people get what you do, and then when you try to implement it, it doesn't seem to match. So actively communicating information as it happens, because things are evolving. And it has to be also communicated in a bite-sized manner. Giving too much info is also a little bit dangerous, because people just don't have the attention span to do that, to actually, especially when you're stressed out. So that when you implement, you should be ready to revise as it go. And it's also important, I put this picture because I put some of our senior AMOs are helping. Leaders or people who are managing need to also get on ground from time to time when you want to implement policies. So policy implementation has to happen in a way that it's not siloed, it's not distant, and it doesn't cause as though that doesn't cause a further divide that can actually happen. And managing this is essentially one of the most important things. Resources, especially PPE. The lack of it can cause a lot of distress, and openly communicating. Let's say this PPE is running short, you got to really tell people that, okay, this is happening. What have we done about it? And the information itself is helpful. And once people feel safe, they will be very self-efficacious and they can be confident in giving support. And so that this I particularly would like to just put it as a slide, so that at least the one take home is just manage this quite well. And I think that would be quite helpful. And this is a bit of what you have in organizations like hospitals, and you have a mental health psychosocial support. This kind of framework is there in most Ministry of Health hospitals, and any outfit, even health clinics also have that. This is our structure in Miri. So it may seem a little bit elaborate, but it sort of grew as we started working through the pandemic. You had to focus on needs. You could be technologically driven. You should be, because in line keeping with the physical distancing, interventions need to be evidence-based. And we on part of these people who run this kind of services, we also have our own clinical load. So when we do this, it's actually there's a lot of extra work. So we need to actually build capacity. So this is how organizations can help people to self-care and care for people in their social circle by actually giving information, training, and also empowering people to look after themselves. So that's an information campaign is kind of important. You can do information campaigns through things like Telegram and so on. And support also can be given to individual people and to groups, and especially managers, and it has to last beyond the pandemic as well. This is some things that we have done in Miri, which I think we found it quite helpful. We actually made this kind of patient workbook to give to the patient, but then it turns out that the healthcare workers in the COVID ward actually also sort of like the workbook, because it's not just to fill time in, it also had some mental health tips and also information about whatever information that we knew about the virus at that time, like how long you will be here, when are your, how often the swabs will be taken, etc. And these books are quite disposable. So you get it in the ward, you use it, and we dispose it. We also have a hotline. We have 2 hotlines here where people can message or call and then get support. We have made, we have 2 lounges now in our hospital. Lounges need to be characterized according to the risks that happen, and so the infections and with infection control protocols in place. This lounges were something that were actually recommended in this Lancet communication because many people didn't have the time to rest. So this is something that was found to be also helpful. And managers need to be also supported. So part of our MHPSS work was also supporting managers and supporting others, supporting the people that who they are responsible for. Managers need buddies because they also need a break. When they are supported, they should be able to help the decision making of in their particular in a particular unit. Because junior colleagues often now are suddenly, some decisions are quite serious. So it's not easy to make a decision as when you're a junior colleague as well. And make sure that people in your unit have actually time and rest, the necessary rest, and working in teams. One thing that is been found helpful is like people should work in one team, but they should be rotated to high intensity work to low intensity work. That has been found to help a lot of people's health. And when something bad happens, you have to, we as people, we have to talk about it. And normally managers have that role to do that, or people who are leading units should do that. Example, let's say like this happened to us in our clinic. Actually, we had a sort of we had an exposure where somebody who came to our clinic was supposedly to be a person under investigation and wasn't wearing a mask. The staff became very anxious, and then everybody was like scared. There was a lot of anxiety. People were scared to work. What do you do about it? We had an honest conversation where we met in the clinic. Then we got the infection control officer, and in the end, it turns out it was just misinformation. And when you clear out that misinformation, people felt hurt, felt they had a place to vent, and finally we could actually also reach to a constructive consensus. That safe space needs to be created in any part of organizations as well. All right, and also of course helping people again on how to go about quarantine and all of that. And nobody should be left behind. While we talk about doctors, nurses, we also need to talk about our cleaning staff. We also need to think about our security staff. So we have done, we've also given self-care kits for people who are doing or picking up extra shifts. And that was actually also something that people appreciated. And it's always okay to work together. I think in Sarawak, we have a Telegram channel that gives out mental health information that helps with our information campaign. We co-produce interventions like with my colleague in Utah, we made an online suicide prevention training in COVID wards so that the staff all can go through that training. It's just 30 minutes and get hotlines especially the people like who run Befrienders and all, they do a lot of work as well. And of course, specialist services for people who need it. And the last bit is that we see about self, we talk about others, we talk about organization. The whole health system needs to use their platform to help healthcare workers and also to combat stigma. Communication needs to be clear. The health system has to work for all, not just a select few. People who often get forgotten are people who are working out of state, people who are single, people who are single people with dependents, like single mothers. So this is actually the diversity of healthcare workers that we have. And so everybody needs to be seen and heard, because when they are seen and heard, they work better, and also we can get through this. And so that this is a really good read, just read the boxes, so that at the end of all of this, we have a meaningful narrative of living through this pandemic versus something that's of trauma. So that's a bit about what I have to share today. Thank you.
Thank you, Ravi. Thank you very much. And I think a lot of things you mentioned are very pertinent and relevant. And I can say from my personal experience, especially the role of the leaders of the teams, leaders of the sections, I think are extremely important. We're going to come to the questions now. And before I forget, since Ravi was the last speaker, I'm going to address the first question to him. You mentioned that briefly in your presentation about the role of leaders. I personally feel that it is key. At the end of the day, the person in charge on the ground looks after the entire team, and they should be close enough to the team members to assess and to know whether whatever levels of anxiety or worries should be addressed. I wonder whether, because this pandemic, of course, is huge compared to whatever else we had in the past, whether this is something that leaders have to train to do. We had no time to prepare as such. We just got on with our work. But what's your specific message to leaders of these service areas going forward? Because as DG repeatedly reminded us that this pandemic is going to last for quite a while, unfortunately.
Okay. I think the most important thing is that leaders, I think it starts with the fact that leaders themselves can get affected. That is the most important thing, that we also can be affected, and you are actually suddenly expected to carry a lot of roles. So I think getting yourself supported is important. Working in a buddy system is something that we have done in Miri, and it is really quite useful, especially for meaning that there's not just one person leading a team, there's another person that if you need a break, you can pass that too. So first, again, if you cannot pour from an empty now it's escaping me. An empty teapot can't be pouring. So you got to look after yourself. And then the thing about what leaders can go through for going to training is, I think leaders can talk to other leaders who are in this thing and get some ideas about how they are coping about it and how to go about about what they're doing, and including sharing best practices, because at the moment evidence generates with the best practice and all of that. And another thing is, this is the role that I found that the MHPSS team in Miri actually did, which was, I personally think the work of Dr. Adam and Dr. Bawe here was really good, is that they actually met the leaders and sort of had sessions with them, working with them to help them face, and also including finding out what are their difficulties and also empowering them with skills. Yeah, I think skills is something that they really need to be empowered, and also training has to go along on the way, and so that they can support. And the best I think any leader can do is actually listen to what's happening in the ground, meaning that let's say you are leading the outpatient clinic, you need to actually step into the clinic once in a while. Let's say you are leading in an emergency department, you would probably want to see what's happening in the green zone, yellow zone, red zone, and not just what the doctors are facing, and even to the part where the cleaners as well as that. So the good leader is someone who knows what's happening in the ground to see challenges and build a rapport so that your people can actually come to you when there are problems. Because we will never be able to think of what all can happen, but when something goes wrong, they should bring it to you. And even if you can't solve it, you work towards working together with them actually sort of helps the thing rather than that. So that's a bit about what I can share about that.
Okay, thank you, Ravi. Yeah, just to add a point, I think during crisis such as this, something especially unprecedented, and nobody has journeyed in this area before in our lifetime. I think clearly as a leader, you must lead from the front. I must say there are leaders who lead from the back, way at the back. And that is, that's not right. And you know who your leaders are if they lead from the back. You have to lead from the front. You cannot send people into harm's way without having some of that experience yourself. And clearly, I think the respect for that leader is stronger when your juniors see you there as well. Obviously, as the head of the section or the head of the team, you may not be doing the nitty-gritty every single day. There are other categories of staff doing different jobs. But the fact that if you lead from the front, I think that respect, the appreciation of the difficulties you yourself have personally faced, will add a lot of value, especially when it comes to PPEs. It's very easy for a leader to say, oh, now you don't have to wear the N95, the surgical mask is fine, but you never appear in the ward. So I think clearly in my personal experience, the only humble experience advice I dare give to leaders currently on the ground, please lead from the front. I think our juniors depend on us to do that. Thank you very much, Ravi. I'm going to move on quickly to the other questions and to other speakers. I've been especially looking out for the post-mortem questions because Dr. Hafizam was quietly waiting for us from the first lecture. So I'm going to go to him first. Hafizam, are you around?
Yes, I'm around, Datuk.
Oh, I see. You're waiting anxiously for your questions. I'm going to give it to you first. Okay. Now, obviously, we know that the forensic team will not need to do post-mortem for every mortality that we have in the country. So going forward, one of the questions here is, how do we choose which COVID-19 mortality case to perform post-mortem from now on?
Datuk, thank you for that particular question. Going forward, we think that the best approach for the next post-mortem, the next cases for autopsy for positive COVID-19 cases that died in the hospital, we would like to examine a case of a young diseased person without comorbid and not been admitted for too long in the ward, because the finding diffuse alveolar damage, usually if that particular patient been intubated for a long period of time also can be seen in intubated patient, diseased person. So if you want to look for that particular pathology due to COVID-19 in our country, that particular diseased person or that particular subject, in our opinion, should be a young, not a very old patient and do not have any comorbid. Based on our experience right now, our health system is very good in dealing with COVID patient. We see that our fatality rate is very low compared with the other country, such as in European country. Their case report also mentioned about a case that died outside the hospital, in which for our setting, we do not have that particular numbers of deceased person died due to COVID-19 outside from the hospital. The one that we have right now in Malaysia is mostly died in the hospital. So moving forward, we think that in forensic services, what we would like to have or examine in order to help clinicians understand this particular pathology of COVID-19 is a deceased person that is young and do not have any comorbid.
I think that's very pertinent and relevant going forward. So basically, we are looking at cases that are not typical as such, isn't it? Like young person with no comorbidities or a pattern of disease that's unusual. So rather than the usual elderly person with tons of comorbidities. We have gone through a lot of the cases in the national committee looking at the mortalities, and as Hafizam mentioned just now, many of them involve older people with comorbidities. The clinical presentation and the progress of the case, it's fairly typical for most of them. But certainly going forward, I think what you suggested makes very good sense. There's another question with regards to autopsies. I know you were very changgay, you got CT scan and everything, so I guess they're asking you this question. What is the indication to perform post-mortem CT scans at HK?
To answer this question, the indication to perform post-mortem CT scan in Hospital Kuala Lumpur, in general, number one, if that particular case subjected for legal post-mortem, number one. But for COVID-19 cases right now in Hospital Kuala Lumpur, we do perform post-mortem CT scan for case died in the hospital, even though do not subject for post-mortem examination as a learning curve, Datuk. So therefore, we can see that particular radiological image of confirmed COVID-19 cases. There are not many case of COVID-19 subjected for CT scan, even in a living patient. Therefore, in Hospital Kuala Lumpur right now, we already have 10 post-mortem CT scan images of confirmed COVID-19 cases.
Oh, I see. Oh, and were there any unusual findings?
That particular finding need to be answered by forensic radiologist, Datuk.
Oh, okay, sorry. Okay, yeah, okay. Thank you, Hafizam. Thank you.
Okay,
Right, okay, let's move on. There are other questions to deal with, and okay, we will ask the mental health experts some of these questions now. There were quite a number of questions in terms of students. So maybe Esther, maybe you can share some of this. From your experience, were there a lot of issues regards to students in terms of mental health issues during this MCO or CMCO? Esther, from your Befrienders perspective.
Okay. Yes. Yeah, Datuk, I mean, from Befrienders perspective and student, yeah, we have received calls from students. They are rather, I mean, the calls that I receive is, she is very desperate lah. She is very desperate. Sorry, what's the question want me to answer is?
About students, what you get a lot of calls from students, and what were these issues about in terms of mental stress for students during MCO or CMCO?
Okay, so for these students call that I receive, although we don't discuss calls, the type of calls, what is it, is like this. But generally speaking, students, they are locked in, they cannot meet their friends. So this is a great, they find that they are lost, they miss their friends, and they have to stay at home and have to cope with the housework and not only the homework. So have a new adjustment at home. Some parents might not that understanding to them. They find that they don't quite understand, their communication breakdown. So she becomes after she said, even I finished my homework, my mom still not happy. She find it's very difficult to stay at home all this while. And she really hope that the school will reopen soon. Generally got some call like this.
Well, I thought you were reading my diary. It sounded like me. Every time holiday, want to run to school, my mother said, useless son. Right, okay. But jokes aside, we always make the assumption that, home is where we get support and we get a lot of stress when we go to work. But I guess I think MCO and CMCO did remind us that at home we have stressors of a different kind. All right. Yes. I want to state categorically, I'm not complaining about my wife. So if my wife is listening, please, it's not referring to you. Okay, thanks. We can move on to the next question. Unless you want something else you want to add, our two psychiatrists, you want to add anything in terms of students before we move to the next question?
Yes, Datuk. Yes, Rostam here. Okay. If I may add few things, I think in terms of technology, our younger generation, the primary school student, the adolescent and university students actually more adept compared to us in terms of technology. So I don't think they have any problem to really work through all the technologies that they need to do their homeworks, their all their works in diploma, their university works and everything. But the pressure or stress that they have is actually from external. Number one, as I mentioned by Madam Esther just now, it's actually about the loss of social camaraderie or the peer support that they have usually as they go outside from home. Number one. Number two, the stress is actually coming from our parents, the parents themselves, because we know that parents that have their own expectation about how their children need to behave, how their children need to do their homework, how their children need to do things with their own kind of schedule rather than the children's or the adolescent schedule. So it's actually putting a lot of pressure to our child. Number three is actually the peer pressure of the other parents that's actually in the group or the communication group, either it's actually in WhatsApp, Telegram, or whatever it is, because some of our parents is actually not really able to understand the issues with other children, which can be issues with lines, issue with data, issue with time, issue with a parent that is working. So all this actually comes together and causing a lot of problems to our children that needs to do their things at home while they are actually technically monitored by everyone, every single parent. I can see that there's a evolving ways of how teachers teach our children online during this very short period. Initially, there's a lot of, I would say, they put up all of students that managed to finish the homework, which is actually not good for other children that have problem with data and everything. But in later part, in which I would say that by today, most of teachers is actually more, I would say, more empathetic towards other children and also other parents that don't have the luxury of data and everything. So the pressure is actually not about need to do this homework, but it's actually the pressure is from outside. So that's what my point. Yeah, thank you.
Right. Yes, I think certainly you're right. I think teachers and as well as students are learning how to cope and learn from this experience on the digital platform. It's still fairly new for many of us. So yes, there'll be certainly stress also as well. Right. Ravi, I'm going to move on to the next bit. I'm going to start with you first and then move back to Esther. Someone brought up the issue of suicides. Now, of course, that's the ultimate, I guess, concern for mental health issues during the pandemic. Did you notice, or were there any increase in issues linked to suicide or parasuicide in your experience, either at Miri or in other places? Maybe Ravi, start with you first.
I think we start with this, that with regards to suicide, I think there is no one cause that leads to suicide, but I'm quite sure the isolation that COVID-19 actually results in can actually worsen existing stresses and sort of complicate the situation. As of now, and also as globally, we do not have, we don't really know of rates or cases presenting to suicide. Of course, we might, this can be many reasons, because one of the things is when sometimes people are isolated, that's one. Then another thing is access to certain lethal methods is also curbed, as well as sometimes it's increased. What I'd like to put apart with the intention for suicide is that in particular, this is something I think I really like to put forward, which is why we actually did the online suicide prevention training, is nursing in COVID-19 wards is very, very isolating, not just for the healthcare workers, but also patients. They don't actually have come in contact with people, so that isolation itself can foster disconnectedness, which can worsen suicidal thinking. So I think that's important. The way is, so that's why we have to have a we have to proactively intervene in this matter, not just and sometimes in this kind of situations when we are facing pandemics, and we have seen anecdotal reports across the world, the pandemic can easily foster helplessness among people, as well as disconnectedness. So handling it with improving connectedness is one way forward. And that's one of the things that we got to do. But I really would like to see about, maybe I want to really hear from Madam Esther about any calls, because I think they actually pick up a lot more on, especially with callers actually that talk about suicides.
Okay. Yes. It leads up to Esther. Yes, Esther. In terms of befrienders, did you get an increased number of calls that may be related to some form of suicide thinking or intention?
Yes, Datuk, thank you. I really agree with Dr. Ravi that this isolation regarding COVID really affect this pandemic really affect our the mental health of most of our people. So if we are not careful, we also be one of them. I mean, now can hear like during MCO. Yes, can you hear me?
Yes, we can. Carry on.
Okay. During MCO, I myself personally did also receive angry call, angry calls. They just take up, the call is just scold, shout. They scold quite badly, and they just hang up the call. I also have such call. So, and they also have call like they just call up and we say, yeah, befrienders, Joe Baru, how may I help you? You say COVID-19, and then they just put down the phone. They also have some like this. And some callers, they are suicidal. Yeah, they just straight away say, I not feel like living. I mean, I'm going to die. So in this way, we will ask whether, are you alone? And normally when after talking, finding it out, like tell me more on this and that. So after talking and listening, most of the time we are listening. I will probe a bit and let them talk more. So in this way, in between, I will ask again whether are you going to die? I mean, intend to die today? Then he said, oh, that I think I will postpone now, but I don't know when it will come back again, the talk. So in this, I say it's normal, the talk will come back again, but whenever you need to talk to someone, you please reach out to any helplines and reach out to befrienders, and befrienders will be there to listen. That's all that we can do.
Excellent, I think, yeah. I want to ask this question about the move on from the suicide to another aspect of mental health, which is, I guess, a proxy indicator of mental health issues as well, which is domestic violence. From the experience from befrienders, did we see an uptick or increase in issues of domestic violence? I know there are other NGOs dealing with domestic violence specifically, but from the befrienders' experience, did you experience that, the increase in domestic violence issues?
Yes, our number of the calls increase did include this conflict in this family. So they normally, actually, they have their fixed schedule, like working time, outdoor, indoors, and then now they're all locked up indoors. So they will have this conflict, unavoidable, inevitable conflict with parents, with in-laws. See, so they just really can't stand already. They say, I keep on. I don't know why I feel so negative towards my in-laws now, although she don't feel that bad before the MCO, all have space. Right now seems like no space for her, so she seems that the negative feeling is getting stronger and stronger, and she also feel like killing herself. So I find that family conflict, we sometimes don't take it as so lightly. It will really lead to suicidal too.
Wow.
And they really need someone to listen to.
We are very complex people. We depend on the laws, but we can't stand them that much. Oh yeah, but I love my in-laws. I'm going to pass to the last question, and I can like both our psychiatrists to answer this, to come on board on this. How do we manage internal or external stigma among healthcare workers? I think this is something very real, and from my personal experience, especially during SARS, certainly I experienced a lot of stigma even from colleagues at hospital for fact, and it made me upset and angry, and certainly, and I made it very clear to them as well. I was wondering whether you can come on board and just share a little bit about this, Rostam and Ravi.
Okay, may I start first? So we are talking about stigma now. Especially the stigma is very real, because when we are dealing with our psychological first aid among our healthcare workers in my hospital in Sultanah, we receive a lot of reports from our healthcare workers in which they say that they're essentially marginalized because of they are working as a healthcare worker profession or professionals. This can come from their own spouse, can come from their friends, can come from their neighbors and their family members, in which can be very demotivating for most of them. Because most of us as a healthcare workers, we are an altruistic bunch of people in which we like to help people. But in this situation in which all people are feeling uneasy about this COVID-19, this pandemic, everything, we are unfortunately become the collateral damage in the process, because we are dealing directly or with most of the positive patients. Even though comparing with the publics, we are actually safer than them in terms of contracting the diseases, because we are protecting ourselves properly while we are working. Unfortunately, people cannot see this. So how we want to manage this? Number one is actually support among us. Means that we must be together in this situation, because to make people understand can be very difficult. To make everyone understand what especially we are dealing with, it's actually very difficult. So it's actually to be with us together. Kita jaga kita. That hashtag, right? Number one. Number two is actually very important in terms of our leadership. The anecdotal reports that I can get from around 2,000 clients that we manage for psychological first aid in Kedah, we can see three things that they need from the leaders. Number one, they want the leader to be able to smile, because they think that whenever the leaders come down to the grassroots, they are afraid of them, because they are waiting for the ridicule, they are waiting for critics, and they are seeing their leaders as a punisher in this situation. So we want a leader that can smile together with the other healthcare workers. Number one. Number two is actually a simple greetings for everyone. Thank you so much. Assalamualaikum. Hi. How are you? All those small things. It's very important to all of our healthcare workers. And number three is actually about our ability to connect, because sometimes the healthcare workers doesn't feel connected to different levels of leadership. So that breaks their hearts in the sense, and at the same time aggravating the stigma that they have, because they think that they are now stigmatized by the publics. They are actually also stigmatized by the leaders and care workers that is not directly involved with the COVID-19, whether they are not in a hybrid hospital or the exact COVID hospital. So there are a few things that is actually making things worse in terms of stigma. Aside from doing this together, I would say that we need to remember is actually we are doing this for the nation. So in order for us to really make things into perspective, we must remember that all of the things that we are doing is actually for the nation. We are doing this for our family. We are doing this for our population. So I would say that we need to put aside all those negative feelings about the people, because as I said just now, we cannot make everyone understand what we are doing, but we can only continue to educate to a certain extent. Yeah, that's all. Yeah. Maybe Ravi can add on.
Yeah, I think Dr. Rostam has spoken about other people that day, but I think I really want to speak about healthcare worker stigma, to other healthcare worker stigma, which is a real thing that actually it sears up from time to time, especially with other colleagues, and even can be colleagues within your own department or other parts of the hospital. And that is actually one of the most distressing, because it actually happens to you on a day-to-day basis. A lot of people, when we did our MHPSS work here, as well as a lot of people still don't know a lot about the virus. Okay, of course, knowledge about it is evolving, but the fact that the need for the misinformation that spreads actually fuels the stigma. So I think as healthcare workers, at least the least we can do is be informed, and I think that's where the hospital level, or actually the unit level, that you actually have to educate people how exactly COVID spreads, and what are the precautions, and how you can meet people and all. And just because you work with a COVID-19 person doesn't mean automatically you are as infectious or of that sort. And I think, and when incidences of stigma is reported, and it should be reported, action has to be taken, where it's not to be punitive to the person who is stigmatizing the healthcare worker, but actually more so to educate, so that information actually spreads. And I think that calling out stigma, calling out discrimination, I think not just in the hospital but everywhere outside is also important, so that people who do really good work should not be put into at risk, should not be put at risk of being marginalized within the society. So I think information needs to be given, as well as there should be avenues as well for people to act when stigma happens to them. There should be avenues where they can they can feedback, and then it is actually handled, and the way you handle it also really matters actually. So that's a bit about that.
Right. Thank you, Ravi. And I think suffice to say, both of you spoke on this issue. I think stigma is certainly real, both within and beyond our fraternity. But I think all of us, as one healthcare fraternity, should defend our own colleagues on the front line. I think we do make each other stronger in that sense. So the time has already caught up with us, and I do have to end. But there's one question I just want to quickly address. I won't ask Dr. Hafizam to answer this because I think it's a very simple question. What they ask is, will postmortem help to define actual COVID-19 deaths and therefore reflect true fatality rate? Obviously, the answer is yes, the postmortems will help us. But clearly, we can't do postmortem, and we probably don't need to do postmortem for all cases. We already discussed which are the cases we are likely to focus on going forward. I'm going to end by letting everyone know that the WHO has given us a new classification a month plus ago on how to classify COVID-19 deaths. And in a very simplistic way, they look at COVID-19 deaths, looking at deaths to see whether someone has died because of COVID-19 or whether someone has died with COVID-19. And the definitions reflect the way it's been framed. So the National Mortality Committee is going through that and has gone through that, and we have adjusted the figures a little bit. Suffice to say that most of the deaths in Malaysia with COVID-19 died because of COVID-19, but there are some cases, and I think it's about 7 to 8% of these deaths died with COVID-19. They died of some other disease entity, including cancer, coronary artery disease. And I think Hafizam showed 1 or 2 cases during the postmortem findings just now. So this has been adjusted, and we leave it to DG to see when and how he wants to release it. But overall, it doesn't change our numbers in a very big way. Our mortality case fatality rate is still relatively low. I think it runs between 1.4 and 1.5, that range. So I just want to finish off that question quickly. Now, time is caught up with us. I want to thank all the 4 speakers for their time. Hafizam, thank you again. I know we have disturbed you a lot the last couple of weeks. Thank you for your patience, and thank you for showing us all the data and all the pictures just now graphically. To our 3 speakers, so Hafizam, thank you very much. We try not to disturb you so much. We don't give you so much mortality to do any more postmortems, okay? We try very hard. For the 3 other colleagues, first, Esther, thank you very much. And I think I've called Befrienders before a long time ago. I think my mother scolded me. Yeah, probably hang out halfway. Prank call, sorry. But thank you very much, Esther, for the service you do for the country. I think you help many people during difficult times. We probably don't say that enough, but thank you for sharing your experience. And I think what you see in the community reflects what we see in the hospitals as well. So, Esther, thank you very much. Continue to do